afternoon. Welcome to our first nurse webinar on nursing solutions, improving Parkinson's care everywhere. We're very excited to launch this new series to showcase the work of our nurse scholars who have completed the Edmund J. Safra Visiting Nurse Faculty Program at the Parkinson's Disease Foundation. A warm welcome to all of our scholars who are listening and also to all of those from the community who have joined us this afternoon. The PowerPoint slide deck can be downloaded from the reminder email you received this morning or from the Parkinson's Disease Foundation webpage highlighting this talk. Health professionals can earn one free CEU through the American Society on Aging. Participants will receive an email by the end of today with steps on how to collect the CEU. You have just 30 days, which is until August 12th, to collect the free CEU. It's now my pleasure to introduce our three speakers. Today we have with us Ingrid Pretzer-Aboff, also Gerry Altmiller, and Joshua Limon. Our first speaker is Ingrid Pretzer-Aboff. Dr. Aboff is an associate professor at the University of Delaware. She's been very involved in the Edmund J. Safra Visiting Nurse Faculty Program. From the very beginning, she participated in our pilot focus group to discuss the program, as well as was in our first pilot group. She continues her activity in the program by being a frequent lecturer on nursing research. Ingrid has done multiple things in her career related to Parkinson's disease, several research studies, including interdisciplinary research, collaborative care, and advocacy. And it's in this role of advocacy that Ingrid joins us today. She has been the inspiration for the first nurse-managed Parkinson's disease clinic in the state of Delaware, and really the first one nationwide. It was her brainchild to start this clinic, which operates under the auspices of the University of Delaware School of Nursing and opened in 2014. I'd like to welcome Ingrid, who will talk on establishing a nurse-managed specialty center for those with Parkinson's with limited access to Parkinson's disease experts. Thank you, Ingrid.
Thank you, Glenn, for such a warm description and for inviting me to speak of our experience establishing a nurse-managed specialty center. And this is for people with Parkinson's disease who have limited access to Parkinson's experts in our region. My name is Ingrid Pretzer-Aboff, and I'm an associate professor at the University of Delaware School of Nursing. We're located in Newark, Delaware, on the eastern coast of the United States. So we're about 2 hours, for those of you that don't notice, we're about 2 hours by car south of New York City, about 1 hour away from Philadelphia and 1 hour from Baltimore. And I am located in the northern part of the state. On this slide, you'll see a map of the Dover and the Delaware region. And this is what our peninsula looks like, with Maryland surrounding us on the west coast, and the very southern part of the peninsula is part of Virginia. The peninsula is about 180 miles by 60 miles. And for people with Parkinson's, they'll need to travel up to 2.5 hours one way to reach experts in Philadelphia or even Baltimore. And that's where our movement disorder specialists are located, so they need to leave the peninsula to get some help. The appointment wait time is about 6 to 9 months in these areas, and patients often need help much sooner than that. As a result, many people don't make the trip, so they rely on their local clinicians and practitioners to help them out. Delaware has a large influx of retired people in the southern part of the state, and many people, after moving here, they quickly realize that traveling out of state to continue to see their specialists is very difficult. They become tired, they feel it's unsafe to make such long trips, and they just don't want to do that anymore. They don't want to burden family members and ask their children to take days off of work to help them drive the distance. And some people actually stay in hotels overnight to see their doctors the next day. So really a lot of people approached us at the university and approached myself, and they asked us for help. So we brainstormed to see what we can do for them. Initially, we decided to have a group of people, and so we consulted with community leaders who had Parkinson's disease, their family members, nurse practitioners with an expertise in P.D., neurologists, family doctors, insurance companies, local government, and local therapists. And we built a model. And what you see here on this slide is the model where you see the patient with Parkinson's and the family members really are central. You can see that the nurse practitioners are surrounding the model. They coordinate patient care and the family. We incorporate family in this very much so. They appear at every visit. And we identify needs during this very comprehensive assessment, the first visit, and also subsequent visits. We engage the talents of other disciplines, all the small circles around this, and help achieve patient goals. So we enlist the help of absolutely the movement disorder specialist on the first visit, making sure the medication is optimized and making sure we have the correct diagnosis. We solicit the help of a mental health care provider as well, and both these specialists we bring in through telehealth, video conferencing, because we don't have that specialty within the state or on the peninsula yet. Physical, occupational, and speech therapists, we do have them speckled around the place, and we also have them right on site. We utilize their help, also the registered dietitian, exercise physiologist. We've helped develop support groups and back them up with either a place to stay or some educational speakers. We have educational programs that we run once or twice a year, and it's a very big draw for the population to come in and listen to what's new or listen to just anything about Parkinson's. And we are a university, so we do have a research team on hand that looks at different aspects of Parkinson's disease. I would say of all of these, patient care coordinator has been the most useful all around to just coordinate all these little specialties. We have 3 requirements to be on the team, and it's important that people have an expertise in Parkinson's disease. We relied heavily on the Ed.D. Stafford Foundation, the V.N.F. training program for faculty, and any of the nurses coming through. We've trained up our nurse practitioners so that they feel like they have an expertise in Parkinson's. We have the backup of the network of people who have gone through the V.N.F. training, so if we have questions or unusual cases, we can always contact them and get answers. So we feel like we have a really good support system for our clinicians as well as our patients and their family members. We ask for experience working with healthcare teams as an active member or in a leadership role. So we need to have people on our team that are used to working with people outside of their field. We also think we need people that are supportive and willing to be engaged in research. As an academic setting, we can look at this model and look at the outcomes that we have witnessed to see if what we're developing is indeed helpful. So the 2 people that we have contracts with currently with expertise in Parkinson's is Dr. Ray Dorsey, who's from the University of Rochester, and Dr. Roseanne Dawkins, who's from Rutgers University, Robert Wood Johnson. Dr. Dorsey is a movement disorder specialist and has an expertise in telemedicine. He's the first person I contacted to see if we could even start a clinic, and he was, oh my gosh, he was so helpful in saying, absolutely, let's go for it. So for the longest period of time, and still is, the only movement disorder specialist that people have access to in our state. You see the picture here is on the telemonitor screen with a camera on top, and the camera does give a wide range of the room, which you see on the picture on the right. That's Roseanne Dawkins. Dr. Dawkins is a clinical psychologist who speaks to her patients through the device as well. So it's a big enough device. The quality of the picture is great, and it never seems to be an issue. People automatically connect with the physician in front of them or the clinician and vice versa. Very small learning curve in using the devices, and we've repeatedly gotten feedback that it feels like they're right in the room with us. It is not a slight quality, it is a much better quality, and that was noticed by our patients as well. Dr. Dorsey started seeing patients in March 2014, and Dr. Dobkin started seeing her patients in August. We work with physical therapists who are right next door to us and work with Parkinson's patients. We work with speech therapists that are right down the hall from us. Very often we can have, people are nervous, we can have a therapist come right to the clinic and then we have a warm handoff so they understand what it might mean to have physical therapy or speech therapy, what it entails. We work with nurse practitioner students right in our facility, undergrad nursing students and other undergrad students of different disciplines. So it's really a very rich environment for education. The students enjoy the experiential learning and the patients enjoy sharing their experiences with the disease. Caregivers also feel like they can share their stories with students, and it actually makes them feel a little bit better that people are understanding, and that way we can help them as well, connect with different resources in the community. So what does a visit look like in brief? There are 3 steps to this. There's a pre-step also. We send some information home to the patients. It's a very comprehensive assessment, so it's a package of forms we want them to fill out before they come so we can assess what different symptoms they might have related to Parkinson's. Then the nurse practitioner will on-site get a complete history, including medication history. She does an exam, or he does an exam, both neurological and a proper healthcare exam, also functional history. And they develop a list as a family unit with a nurse practitioner of what are the healthcare goals. The second step of this is we roll Dr. Dorsey into the room by the telemedicine cart. He provides an assessment of physical Parkinson's history, current issues, symptoms. He and the nurse practitioner and the patient develop a plan of care. He might, because we can roll him in and out of rooms, he might request that watching the patient walk up and down the hall and look at balance would be very helpful. So that's easily done with our technology. In step 3, recommendations by Dr. Dorsey in conjunction with the nurse practitioner, ordering any lab work or any referrals, discussing any research, devising educational and supportive plans for the patient. I think depending on the needs of the patient, the nurse practitioner will bring back the person, the patient and family member, if that's warranted, in a couple of weeks. So it might be we change the medication, we want to make sure they understand it, or perhaps we just want to see if the symptoms are controlled. But we have that latitude. We do not have to have Dr. Dorsey in the room with us every time we bring back a patient, but start bringing them in the room with us for our 6-month checks and our yearly checks. Works out very, very well. Our results to date, we've had more than 250 patients that we have served. About 10% turns out did not have Parkinson's disease. That's not unusual in this population, but it's always good to have a second person as a specialist look at a patient to see if indeed that is what the diagnosis is. Mostly when it's not Parkinson's disease, it might be Lewy body dementia, or it could be essential tremor, in which case treatments are extremely different. We have about 20% patients have accessed our telepsychology. Some people come to us directly for that reason. Don't want to switch doctors, but they absolutely want to have that extra psychological support. We do research and education therapies right on site. Patient satisfaction has been excellent. So they've reported 4.6 to 4.8 out of a high of 5. Communications clear. Their healthcare needs have been met. They would recommend to another person that they would use this telemedicine video conferencing to see the doctors or the clinical specialist, or even they just come in and see the nurse practitioners. Many times they're citing that we spend a lot more time with them than a normal, just a physician visit. They appreciate that because they're very complex disease and they have a lot of symptoms. They're not quite sure, is it related to Parkinson's or not? So other patient-perceived benefits include that they like the local access to a movement disorder specialist and a clinical psychologist that has expertise in their issues and their problems. They like the use of a multidisciplinary team, early and accurate diagnosis. They very much enjoy and appreciate the decreased wait time to see the movement disorder specialist. They like that they're surrounded by educational venues and programs more easily here. And, of course, they like the decreased travel time. And we've saved as much as 1.5 hours of travel or 80 miles in one direction, especially on a bad weather day. The lessons learned and things to consider if you're thinking of starting a clinic such as this, a multidisciplinary clinic, which is as much of a hybrid, because sometimes we use the video conferencing and sometimes it's all the care we have right on site. If you need a person to coordinate the logistics of having the person go through the system, should it be the nutritionist or should it be the therapist, which is the therapist, and when should they come, involving their insurances, what is covered and what is not. The movement disorder specialist serves as a consultant in our situation. So since he is off-site, he's upstate in New York and we're in Delaware, he is unable to write the prescriptions. We have nurse practitioners that can write prescriptions, or we just send a consultant to the local physicians or neurologists and they can write the prescriptions. So there's many ways to do that. We do have to consider consent. There's probably more consents through our system than any system you've seen. So consents have to be obtained if information is exchanged between any of the sites. So the patient has to give us permission to speak to the clinical psychologist, or for Dr. Dorsey, if Dr. Dorsey wants to speak to the clinical psychologist, or if the hospitalization is decided that we can all speak to each other. So those are a lot of moving consents. Preparation to the visit. As mentioned before, we have pre-visit paperwork, and it needs to get to the teleprovider offices prior to the visit, so that's a little bit of a coordination. And consultant letters need to be read and disseminated to make sure everything's followed through there. And, of course, one of the lessons we learned is reimbursement. It's different in every state in the United States. So overall, federally speaking, Medicare does not cover telemedicine right now. But depending on the state you're in, and Delaware is included in this, private insurances are obliged to pay, and in fact they're mandated to pay if they were covering face-to-face visits. They have to cover telemedicine visits. So that's a work in progress. So right now we're funded with soft monies, grant monies, as well as some insurance reimbursement. There are many people helped us to get as far as we are right now, and that includes the Parkinson's Council and then staff for visiting, our own college, and our deans. So thank you for everybody. So I think I have some time for questions, or those questions will be at the end.
Thank you very much, Ingrid. I'd like the audience to know that they can submit their questions at any time by clicking in the text messaging box on the bottom left corner of the computer and then hit send. We'll hold the questions until all of our three speakers have completed their presentations, but you may submit at any point. I'd now like to introduce our second speaker, Gerry Altmiller. Dr. Altmiller is an associate professor at the College of New Jersey and also a clinical specialist at the Albert Einstein Medical Center. She's an exceptional teacher, and she was the recipient of the Lindback Award in Teaching for 2014. Much of Gerry's work has been devoted to quality and safety in nursing education. And as part of her project for the Edmund J. Saffer Visiting Nurse Faculty Program, she was able to develop an unfolding case study applying the A.C.N.S competencies to the care of patients with Parkinson's disease. This is available, and not only is it available, but Gerry presented her case at the annual meeting of the A.C.N.S Association in San Diego in May 2015, where it was listed among the top 5 highlights of the conference. We're very proud of the work Gerry has been doing, and very happy to have her join us today to talk about integrating A.C.N.S competencies in Parkinson's disease care.
Thank you, Gwen, for that lovely introduction. So today I would like to share with everybody my experience with the SAFRA Visiting Nurse Faculty Program and what that did for me and how that changed me as an educator. My main role in nursing is that I work as a nurse educator. I mostly focus on pre-licensure nursing education, but I also teach grad and doctoral classes. So when I was thinking about all that I knew about this, I thought I had a great understanding about Parkinson's disease and was teaching it very well for the last 15 years. And then after spending time in the SAFRA program in the didactic and the clinical portion, I realized I really was not focused on what students need to know to go out and safely take care of that population. So when I tried to think about an appropriate project that would really be helpful, I thought a good thing to do would be to create an unfolding case study of a patient with Parkinson's who was placed in a hospital setting and the care that really was specific to that Parkinson's disease patient who had another health situation going on. So I decided to use the A.C.N competencies as a framework for creating that unfolding case. A.C.N is Quality and Safety Education for Nurses, and I have been associated with them for 10 years. I work as a consultant for them, and I'm on their advisory board. The A.C.N competencies take the IOM, Institute of Medicine competencies, and reframe it in nursing language and nursing action so that people can implement those IOM competencies. The IOM competencies are the mandates that every healthcare practitioner should be bringing into their clinical practice. So A.C.N took those 5 IOM competencies, added an additional one for safety, and then created a framework for people to create teaching strategies. So I created this teaching strategy with the main focus on safety, which was about minimizing the risk of harm to patients and providers through both system effectiveness and individual performance. So the difference with an unfolding case development and a case study is that when you lay out a case study, you tell the entire story and then the person addresses some particular problems in it. With an unfolding case story, you tell a story, and with each slide or each piece of the presentation, a new problem presents itself, and the person who's participating in your case study has to make a decision. So there's decision points along the way that affect how the patient's going to be cared for. The other thing that's interesting about it is that it follows a specific patient through the process. So when I developed this unfolding case study, I created a patient who had P.D. disease, but also had other underlying things like BPH and was in for a hernia, admitted into the hospital for a hernia repair and was now on the post-op unit. And the case study starts with the nurse first making an assessment of the patient and meeting him in the post-op unit. So to give you some examples of how I integrated the A.C.N competencies with the PD education pieces that my student needed, I have some slides here to show you some of the ideas that were on the different slides. The actual case study is 30 slides long, and each slide lays out a situation where the student has to answer it or think about it, and then the answer is on the very next page to try to confirm what they know or what they have decided to do for the patient. So for teamwork and collaboration, part of the slide reads, during team huddle with surgeon and medical resident, you report concerns from your AM assessment, which include Mr. Conley's slurred, soft, slow speech, expressionless faces, drooling. Additionally, he appears thin and frail, and there is a noticeable tremor. So in doing this, the student not only learns the symptoms that are concerning for a patient with Parkinson's disease, but also learns the piece about bringing that into the team and involving every member and sharing that information and communicating it well. For the A.C.N competency of safety, there are so many pieces with Parkinson's disease that connect. So one of the slides that I ask, I say to the students, what are you concerned about for this patient? So after they have all this assessment data, they have to think, what am I worried about? And then they get an opportunity to talk about it and throw out answers. And then, of course, on the very next slide, I have the things that I want them to be concerned about, which they usually hit on that. So one of the big things they hit on is the aspiration risk, because the patient is known Parkinson's disease, has poor muscle control as evidenced by speech and swallowing difficulties, or the idea that the patient is a falls risk because they have known Parkinson's disease, they have trouble with postural instability and trouble initiating movement. This patient just had a hernia repair, so he's post-anesthesia. That adds an element to the falls risk. He has an IV infusing. He has a frail appearance and the need for the PD medication. So things that I do is say, well, how would you best address these concerns? And then students get an opportunity to talk. So it's a different approach to teaching. Rather than just providing information, you're getting them to think through it and make some clinical decisions about the care. Where evidence-based practice needed to be brought into it, I used theory burst. So a theory burst in an unfolding case study is where you step out from the patient's care and almost have like a commercial of theory that they need to know. So an example of a theory burst in the unfolding case study is I used a slide to talk about PD medications and that their aim is to correct imbalance of neurotransmitters in the brain, and that they have a short half-life, and over time patients develop wearing-off doses, dyskinesias, and on-off phenomenon. So it's an opportunity to step out of the story, teach something quickly to them, and then step back into the story with the patient so that they are back involved, and here I am, the nurse, caring for this person. For the patient-centered competency, I used a scenario that people see all the time in the hospital where a family member arrives and they are concerned because they don't think their family member is getting the care they need. So on that slide, Mrs. Conley arrives and she is there to help with Mr. Conley's AM care, and she asked to speak with you. He hasn't gotten his meds yet today, and he didn't get them yesterday because of his surgery, and he never looks like this at home. Why can't he get his meds? So we put the student in the situation with, this is what the patient's family is asking you. What are you going to do now to address this patient's concern, to address the family's concern? How are you going to turn this around into a good outcome for the patient? So the students get to throw out ideas and think about that, and I help to support that and facilitate that. One of the greatest priority in patient safety right now and in the national patient safety goals is to conduct a medication reconciliation for every single patient that's admitted into a healthcare institution. We know for a fact that multiple doctors are ordering different medications. There's interactions, there's things being missed and things that don't make sense. And so every hospital really needs to have this as part of their admission experience. So I thought this is a great opportunity to teach students about medication reconciliation while they are learning about Parkinson's disease because of the complication of the meds and all the comorbidities that go along with being in that geriatric stage of life. So the students conduct a med reconciliation. It gives them an opportunity to review through the meds and talk about interactions, and also to go through that safety process that's such an important part of our national patient safety goals. And then the final piece of the unfolding case study is the idea of quality improvement. Currently in our healthcare system, we really need to rethink about how we deliver care. We can no longer teach nurses just how to do the job, how to put in a Foley catheter, how to insert an NG tube. It can't be about that anymore. It really needs to be about a student needs to learn how to do my job, but I always need to be focused on how can I do my job better. And so everything that we teach, whether it's pre-licensure, grad school, or doctoral school, really needs to have that focus. How do I do my job, and how am I going to stay focused to always be doing that job better? And that is what quality improvement's about. So to bring that piece forward in the unfolding case, I have a slide where it says, after caring for Mr. Conley, what improvements can you suggest for the care of hospitalized Parkinson's disease patients? And students have great ideas, and they bring them forward, and they share all of that with the class. So some of the ideas that came out of it and some of the ideas that I facilitated them to think about are to take PD information to the Falls Prevention Committee of the hospital and have a hospital-wide approach to prevent falls in this population. That every time we transfer a patient between care, we should include falls and aspiration risks as part of that report. That the staff and pharmacy education should really focus on how important it is to give PD meds on a strict time basis so that people don't have gaps between the time they should get the med and the time they do get the med, because that will help to prevent falls and prevent aspirations. the use of multidisciplinary teams, that everybody has something to contribute to the care of this patient, and the implementation of programs such as the Lee Silverman voice training program, the Big and Loud, so that people talk loudly and that people take large steps. These pieces help to improve their communication. It helps to improve the safety of their gait. So these are the things that we really need to promote. Nursing, pharmacy, and IT really can work together to flag PD meds, timing, develop alert systems. So I used the unfolding case in class, and I had the good fortune of having a student in the class who had a personal experience that his father had PD, and he was very generous in sharing about that experience in class. And so afterward, he approached me with an idea. At the College of New Jersey, we have a quality and safety newsletter that I serve as the editor for. And the purpose of that newsletter, it's 2 pages long. It's very short. It's published 3 times in the fall and 3 times in the spring. It's all student-written articles, and we invite students to write about something that has to do with patient safety or quality improvement. So after the Parkinson's disease presentation in class, he came to me and he said, I would like to write an article for the newsletter about Parkinson's disease. And I said, that would be great as long as you focus on some kind of safety aspect or quality improvement aspect. So he wrote about disparities in healthcare, and it was a fabulous article that was an integration of his personal life experience with his family and the things that he learned in class. And the newsletter got shared with everyone in the school, faculty, students alike, all levels of the program. So it was a nice opportunity to feel that we were preparing the next generation, lighting a fire in the next generation to give better care to Parkinson's disease patients. So with that, I'm going to stop talking now and give an opportunity to that student who is now a registered nurse, graduated and passed his boards just this month. I thank you for your time, and I'll be glad to answer questions when we are done.
Thank you very much, Geraldine. I think everybody can echo with me how exciting you make us feel for your passion in this field and all the work that you have been doing. And it is so wonderful that we do have your student, Joshua Limon, with us today. And he was inspired by you, but I think you've been inspired by him as well, it's fair to say. I'd like to introduce Joshua. He's a recent graduate of the College of New Jersey, and he also is an NCAA collegiate baseball player. So he's got a lot of talents going there. Joshua, as Geraldine mentioned, approached his instructor that he'd really like to be more involved in the quality and safety of Parkinson's, and I've read his work, and it is truly excellent. He did a lot of research for his capstone paper and really has done a lot of thought and really, I think, learned what we hope all of our students will learn as far as care for the Parkinson's patients. But I'm going to let him tell you himself about his perspectives on the challenges to Parkinson's disease nursing care. Welcome, Joshua.
Thank you, Gwen, for that wonderful. Hello, everyone. As she said, my name is Joshua Lyman. I would like to start by thanking Gwen and the Edmund J. staff for visiting nurse faculty program at the Parkinson's Foundation for having me here today. And I'm honored to be here and share my work. I want to start by telling you all a little bit about my background. I'm a recent graduate of the College of New Jersey and will begin my nursing career at Duke University Hospital in the Surgical Trauma Intensive Care Unit. And I just recently found out I passed my board, so this is a very exciting time. I'm a former student of Dr. Altmiller, and she was an amazing mentor for me, and I can't thank her enough for all of this help on this journey. I was a 4-year NCAA baseball player at the college and have been in and out of doctors' offices for injuries throughout my life, so I've always been interested in healthcare. But I didn't decide to major in nursing until after my freshman year. I was sick, and my nurses were absolutely outstanding, and that prompted me to make the career change. And since then, I haven't looked back, and I love this profession and look forward to bettering it every day at work. So I became interested in Parkinson's disease when I was 13 years old when my father was diagnosed. He was 49, and it wasn't until 4 years ago that I really began getting involved in his care. he was seeing a general practitioner who was mismanaging the disease, and his condition started to go downhill. And for me, it all capped off with seeing him not be able to get up out of the chair one day. And this is when I really started researching Parkinson's disease a lot as a nursing student. And I found out that his general practitioner kept increasing his dose of the drug Sinemet without putting him on any adjunct therapies. And this is when, after discussion with our family, we decided to switch to a movement disorder specialist, and his condition had marked improvement almost immediately. He began taking new medications such as a dopamine agonist and a monoamine oxidase type B inhibitor, and his dose of Sinemet was decreased. The movement disorder specialist also sent him for physical and speech therapy. And at this point in my junior year, I was prompted to begin researching clinical guidelines on Parkinson's disease. And what I learned was both surprising and frustrating. And I've learned that there is no clinical guideline for diagnosis and treatment of PD in the United States. Many other countries around the globe, including Holland, Canada, Scotland, and other European countries, including the European Parkinson's Disease Association, have guidelines. And it's also worth noting that the International Parkinson's Disease and Movement Disorder Society has consensus statements, clinical criteria for a diagnosis, and a recently established task force to improve the treatment and diagnosis of this disease. In the guidelines that I read through, there were a few key highlights that I found in each one. Each guideline specified that it is of great importance that the diagnosis is made by a movement disease specialist. Next is that each guideline says that we should practice evidence-based medicine and evidence-based practice in nursing when treating with pharmacological therapies and adjunct treatments. And lastly, the guidelines specified that a movement disorder specialist needs to make a timely and appropriate referral for one of the two surgical interventions available to help with the disease. And as many of you know, these include the deep brain stimulation and the duodopa pump. And if hearing the information from the clinical guidelines isn't convincing enough, I found some astonishing statistics from the United States. The accuracy of diagnosis by a general practitioner is just 73.8%, yet 88% of patients receive their initial diagnosis from a generalist. Next is that 1 in 3 patients with a tremor as a symptom receive an inaccurate diagnosis. The next statistic really hits home for me and is very accurate. 58% of patients in the United States with Parkinson's disease don't see a neurologist or movement specialist within the first 4 years of diagnosis. And lastly, I would like to note that with a correct diagnosis from a movement disorder specialist, the diagnosis still needs to be continually reevaluated as patients' symptoms are forever evolving. Sorry, I had a little trouble with my slides there. So now let's talk about this from a nurse's perspective, whether we're in the hospital or a long-term care setting or a home setting. And this really is a health disparities issue. The most important thing that I have learned from my father and from my patients is that it's absolutely crucial to give the PD meds on time, every time. And this should be absolutely non-negotiable. We need to teach our patients in the hospital that they must demand this, because 3 or 4 patients in the hospital with PD did not receive their medications on time. This leads to symptom deterioration, patients to have longer stays, and up to 44% do not recover to their pre-hospital state. Patients with PD in the hospital also have higher rates of confusion, infection, pneumonia, and falls. And I say all this because I hope it makes you realize that it really is a health disparity issue. These issues that I'm talking about are all preventable by using evidence-based quality nursing practice. Nurses can really improve upon these problems by practicing basic functions. We need to advocate for our patients to get a correct diagnosis and treatment by a movement disorder specialist. We need to educate our patients and also other nurses of important issues and timely medication administration. Meds need to be given on time, every time. We need to care for our patients in the safest way possible, which means giving out medications on time, every time. We should also refer our patients to the multidisciplinary team, including specialized programs that were mentioned earlier, like the Lee Silverman LSPT Loud Speech Therapy Program and the LSPT BIG for physical therapy. We also need to encourage our patients to take advantage of support groups and community resources. After talking with my father since he joined a Parkinson's disease support group, he has told me that he's had marked increases in his emotional well-being. Lastly, I would like to let you all know about the A.P.R.N care kit for our patients in the hospital. In this kit, you will find a bag to store medications and materials, a hospital action plan, a Parkinson's disease ID bracelet, a medical alert card, a medication form for hospital visits, a Parkinson's disease fact sheet, reminder slips for healthcare team members, and a magnet. I'd like to finish this presentation by saying that my father is doing great, and he and I golf 3 times a week together. He's getting ready to have the duodental pump procedure, and we're all very excited for this. Again, I want to thank everyone for allowing me to be here with you today, and I'd be happy to take questions.
Thank you very much, Joshua. We are certainly very proud of all you have accomplished in what is just the start of your wonderful nursing career, and we're so glad you could take time out to be with us today and share your insights on these challenges, which are so important in Parkinson's disease. For the audience, we'll be ready to take questions now, and you can submit your questions by clicking on the text messaging box in the bottom left-hand corner on your computer and hit send. And we have several questions that have come in, and so I'm going to just get started with the questions, and the audience can continue sending the questions in. This question is for Geraldine. Geraldine, can you share a link to your unfolding case study, if it is available to us all? And also, is your newsletter on quality and safety that's published 6 times a year something that you can share with the public, or is that internal for your school?
Thank you, Gwen, for that question. Yes, I can share everything. Everything that I do, I'm happy to give away. The case study is available online at www.qsen.org. You can download it. All the slides are there and instructions how to do it. I will tell you that if you email me, which I think that that Gwen is going to provide access, if you would like to email me, I'm happy to send that to you directly. As far as the newsletter is concerned, I'm very happy to share that with you. I can give you the template and a few copies of our newsletter. Particularly, I would share this one that Joshua submitted to. And I can also share with you the ideas that I put into the newsletter, and you can pick and choose what things you might want to help your students with. The process of the newsletter is that I go to the Student Nurse Association meeting, and I ask for all of them to consider writing for the newsletter. Plus, in every class, I campaign for people to write. I will tell you that I give them the topic to write on, and I give them the supplies. I have students lined up all the way into the fall, the end of the fall of this year, that want to write for the newsletter. So they really want an opportunity to share what they know. With a little bit of guidance and help, they can do it. So, yes, I am happy to give you everything that I have for this.
Thank you very much, Geraldine. Thank you.
Mm-hmm. Mm-hmm.
I have a question here for Ingrid that has come in. And Ingrid, I think everybody is really interested in your funding sources. And I know probably that could be a talk in and of itself for another whole hour. But basically, can you just kind of run through what are your top funding sources? And being affiliated with the University of Delaware, are you in a situation where your clinic has to be a money maker or a break-even situation? Just a little insight on that, if you don't mind.
Oh, sure, absolutely. I have embedded the Parkinson's Clinic in a nurse-managed primary care center, so I was very fortunate that Dr. A.P.R.N at the time, who was the director, allowed us to just use the nurse practitioners and the front staff and the back staff and the billing office and the whole facility. We are an academic institution, so we do use this site also for education. So we hope to break even. Not always the case. But it's a nice place for us to be because we have all these resources. I use private funding from people through donations that are very appreciative of our work. The college itself, it helps support the Parkinson's Council, which funds some projects that they deem worthy, and we're very appreciative to them for giving us money on an ongoing basis so that we can stay open. then small grants, according to what research we're doing, help support the mission as well. That's all soft money. Then also we're looking at different ways to have just insurance pay for this. So every time a nurse practitioner sees a patient, that's just like any other clinic. The patient would pay for the service, their insurance would cover. We have a sliding scale also if patients can't afford it. So between those different fractions, we're able to keep the clinic going. I don't think we're in the hole. I think we're breaking even right now. It's on Medicare patients where I can't get reimbursement for, and that's where I have to get the money from outside sources.
Thank you very much. Thank you. Always a challenge, I'm sure. Josh, we have a question for you from the audience. Many of our audience works in the acute care settings, and they certainly, I think, believe in medications on time, but can you give us a little bit more information about what some of the confounding factors are and why this is so difficult for staff to comply with, in your view, being new as a new nurse? What have you learned about the challenges of your daily life in fitting these medications in?
Sure. Well, thank you for the question. I'd like to start by saying that even as a nursing student and having a patient with Parkinson's disease, when you only have 2 or 3 patients, it even was tough for me then to get the medications on time. But through prioritizing my day as a new nurse, I have been able to really schedule out and make time for going to give the Parkinson's medications to the patients with the disease, because I see firsthand every day when I'm at home the detrimental effects it can have if somebody with the disease does not take their medications. And trust me, I know that things come up and there's emergencies, especially in the acute care setting. There's things that you have to go do. But through delegation and working with the entire healthcare team, it's possible to get everybody their medications on time.
Thank you very much, and I hope that all of your staff around you learns this from you, because it's such an important issue, a really important issue. Another question for Ingrid has come up. When in the process do you refer your telehealth patients for mental health? Is it an automatic referral at the beginning or as needed? How does that work in your telehealth center?
That's a good question. We do use instruments and questionnaires, and in this case we use the geriatric depression scale as a screening mechanism before they even come to us. In the conversation of the nurse practitioner evaluating the patient, they'll ask questions about mood. And because we have a lot of education surrounding the psychological issues of people with Parkinson's, people are more apt now, because they know more and it's part of the disease process, that they're more likely to come and ask us for help. So it's multiple different ways that we do that. I've had several phone calls from family members or even patients themselves are asking us for access just to our clinical psychologist. We do push them through the system, though, so that we make sure the medication is optimized. That's really key, and that the diagnosis is correct. And Joshua will really punch that out as a very important piece. So we make sure everybody's on board with everything about the medications, looking at their mood, asking them, assessing them. Does that answer the question, I hope?
Mm-hmm. Very well. Thank you so much. Thank you.
Great.
We have a question for Geraldine here. Geraldine, you really covered a lot of information on Parkinson's and also very competently, addressed the cues and competencies in that. One noticed that the mental health wasn't included in that, but I suppose it could fall into a lot of the areas of the cues and competencies. Do you have any comments on that?
Yes, it absolutely falls into every area of the cues and competencies, which is what made making an unfolding case study so perfect for Parkinson's disease, to align those two pieces together, because you do evidence-based practice with Parkinson's. Safety is such an important focus. Quality improvement is so important. Communication and teamwork with all the different people involved with the patient care is so important. And this whole idea of patient-centered care, Parkinson is the perfect disease for that every patient presents differently and has a different set of problems and a different set of circumstances. So that's what made aligning those two entities so well. So yes, in that Parkinson's unfolding case study, every single Q-SYN competency is addressed.
Thank you very much. Thank you. We have a question for Josh that has come in, and we have a question about why aren't the meds that we have for Parkinson's time-released or given by a pump to keep the dosages regular? Well, we do have some controlled-release versions of carbidopa-levodopa and also the agonist, but you mentioned in your presentation that your father will soon have a pump. Can you describe that a little bit for the audience?
Sure, I'd be happy to. And this is something that has taken a lot of thought for our family because it's still a surgical intervention. And it depends on what stage of the disease that the patient is in. And if they fit into the window of having the disease for 5 or 6 years, according to everybody I've talked to, that is the perfect window to have the procedure done. And it is actually much like an insulin pump. There's a small subcutaneous catheter inserted, and the pump gives a continuous dosage of the drug throughout the day. And this allows for 4 to 6 more hours of on time throughout the day for the patient. And they will go to bed at night, and their off time will be while they're asleep at night. And they will wake up in the next morning, and the pump will start the dosage again. And that is my understanding of it, that I've talked to my father's healthcare provider and other nurses and nurse practitioners, and I can't say how excited I am for this procedure to finally be getting some publicity in the United States. It's been getting done in Europe for years now, and it was just approved by the FDA in February to be done in the United States. So it's very exciting.
Right. That's true. It has been available for many years in Europe and with a lot of success. So we are thrilled to be able to have it in this country finally, FDA approved. Geraldine, could you repeat the website that you gave out earlier? I think a few of our listeners missed that.
Yes, I'm very happy to share that. It's the Q.SYN website. It's www.qsen.org. And it is listed as teaching strategies. That's one of the headings across the top, and you click on that, and it will be on the very first page since it is newly developed in the last couple of months. If you have any problem accessing that, please feel free to contact me at my website, at my email address at the College of New Jersey. I'm happy to give it to you.
Thank you very much for your willingness to share all that. Ingrid, we have a question for you. The listener would like to know if patients are followed exclusively by the telehealth clinic when you're following them, and what is the frequency of visits?
Thank you for the question. The nurse practitioners are seeing the patients every time they come in. If the need to see the movement disorder specialist, then we use video conferencing. If there's a need to see the clinical psychologist, we use video conferencing. It is the nurse practitioner that really has enveloped the patients and helps them through all the pieces, and they will often see them on their own for the follow-up visit. It's when they feel like the patient needs to have an adjustment in their medication that gets beyond their skill level, then they'll go ahead and arrange a follow-up with the physicians.
Thank you.
About every 3 months is the usual for a patient. Every 6 months we bring them in to see the movement disorder specialist. So it's very similar to what is face-to-face visit. I do have a comment, though. Can I ask, this is not our protocol, Joshua, can I ask Joshua a question?
Sure.
Joshua, you were talking about, and I totally agree with you, the medications on time every time, especially in a hospital setting. Some of the hospital settings around in this area, we're talking to the nurses in the hospital, the people that can make changes. They tend to use their own time frame. So hospitals might give their daily medications at 8 o'clock, is an example. So I try to stress, and so tell me if you agree with me, is the medication on the patient's time is really key.
Sure. Thank you for that question. And I would have to agree with you and say that the medication being on the patient's schedule is key because they are coming into the hospital already on their schedule. And that's what the A.P.R.N care kit, I believe, tries to do. So if we can advocate for our patients to have that, they can write out their medication schedule so that the healthcare provider and the nursing staff can try and work with the patient together to ensure that they get their medications on their schedule rather than on the hospital schedule.
Thank you.
Thank you.
Thank you, Joshua and Ingrid. And also, I'd like to just let the listeners know that those kits are available free to patients, families, or even to nurses if you want to have one on your site available. And that number to order them is 1-800-473-4636. We have one last question here, and I think I will handle that very briefly myself. Are the nursing schools adding more education on Parkinson's? I learned very little in nursing school. Well, that was my story also. And I think in my nursing notebook I had one line which said, "Watch for levodopa, it will come soon." So that sort of tells you my age as well. But that's the extent of my education. The Edmund J. Safra Visiting Nurse Faculty Program has been in existence now for 7 years, and we are starting to see that schools that send faculty do really take a turnaround in the amount and accuracy of education they give on Parkinson's disease. We certainly have a long way to go. There are a lot of schools in the United States, and not to mention other countries as well. So we need more and more nurse faculty involved so that they can understand Parkinson's. One of the interesting survey questions that we had posed to nurse faculty before the question was, do you feel confident in talking about Parkinson's disease to your class? 70% said no, they do not feel confident. So that shows you without a program that really focuses on Parkinson's disease to bring those nurse faculty really up to comfort level with the information, change won't happen. But we're working on it, and we need more people helping us, and hopefully we'll carry this program on so that more and more nurses do learn about Parkinson's. At this time, I'd like to thank all of our listeners and talk a little bit about the webinar survey that you'll see on your screen. This is very important, and we do hope that you'll take a minute to complete it. It will really help us refine our programs. This is our first program, so we're looking for a lot of feedback. We're also looking on how we can improve it, as well as new topics that the audience may like to hear about. We appreciate such a good turnout and such interesting questions from the audience for this, our very first pilot webinar. And certainly thank you for your participation. If you have colleagues who were unable to join today, the webinar will be archived and available for the first 30 days. Continuing education credits can still be offered. After 30 days, it will be archived, but not with the credits. So please encourage your colleagues to listen if the information would help them as well. I'm sorry we couldn't handle more of the questions, but perhaps we can get a way to get the information out to you even after our time here is concluded. And with that, I'd like to thank everybody for today and encourage you to join us on Tuesday, October 25th at 1 o'clock for our second webinar. The topic will be Simulation Laboratories for Parkinson's Disease Care. I'd like to thank the Edmund J. Safra Foundation and the Lundback LLC for making this series possible. Also, if you're interested in participating in the Edmund J. Safra Visiting Nurse Faculty at the Parkinson's Disease Foundation course, please visit the Parkinson's Disease website for more information on our upcoming programs and how to apply. Thank you very much. Goodbye.